all for now. Artis, I'm ready to hand it over to you.
All right. Thank you, Marie, and very good with the introduction. So
Thank you.
thank you everyone for joining us again on the another, I think when I do my next COVID-19 webinar, I'm going to call it, oh no, not another COVID-19 coding and billing webinar. But I do want to let you know that the presentation is current as of today. And of course, we can always expect changes. So our agenda today, I'd like to go over the diagnosis, the 2021 diagnosis reporting updates, any pertinent current CPT and HCPCS coding updates. I want to touch base on some reimbursement issues, and then there are some regulatory updates that we'll be going over as the last part, and then we will have time for some questions and answers at the end. So we'll be able to cover those. So at the last webinar that we did, there were quite a few questions that came up regarding the 2021 diagnosis code reporting. And so I just wanted to take some time and cover that information as it relates to our COVID-19. And just to kind of give you an update, the guidelines were updated. Of course, the updates came out October for 2019, and then they were updated to give us guidance for reporting the COVID-19, and those became effective April 1st of 2020. And then our normal cycle, again, then they changed in October of 2020. And then the fun part is that new diagnosis codes were released January of 2021. So the guidance changed again. So it's very important that you look at your date of service, your date of discharge, to make sure that you're using the correct guidelines that were in place at the time of service. And it is fun because CMS does like to do what we call time travel. And I'll give you an example of that when a little bit further in the presentation. All right, so the diagnosis coding for October 2019, the guidance, so this would be the guidance prior to the April 2020 updates. And we were told if the person is positive, COVID-19 positive, code that with the B97.29, the other coronavirus, as the cause of diseases classified elsewhere. Now, if the patient was symptomatic, then you would code the symptoms. And I gave an example here of cough. So there's, since it's respiratory, there's also the examples that they gave of, like pneumonia. Now, and then the asymptomatic patients, we were told to code either with the Z03.818 for the observation for suspected exposure, or the Z20.828, the contact with and suspected exposure. But that guidance changed kind of midway for part of that back on August 5th, because, trying to keep everything with the with the first what it was would have been easier. And then at this time in October, they did not address how to report sequelae. That was addressed later. So then on our walking through the timeline for effective April 1st of 2020, if the person was COVID-19 positive, we finally had a diagnosis code, the U07.1 for COVID-19. The symptomatic was to code the symptoms, such as our R05 cough, the J12 for the pneumonia, et cetera. For asymptomatic, then we were told to use the Z20.828, your contact with and suspected exposure to other viral communicable diseases. And then this is where the guidance for the sequelae came in, that B94.8, the sequelae of other specified infectious and parasitic diseases could be used. But it's important to note that the documentation must show the causality between COVID-19 and the patient's symptoms, and that causality may not be assumed. So just because they happen together does not mean that it's related. And a good example of that is for the blood clots that are occurring in some of those diseases. Right now, they're saying that for the Johnson & Johnson, they're not sure that causality, that the blood clots were a cause of the COVID-19 vaccine. However, I was just reading earlier this morning that some physicians in the European Union have found a cause between the COVID-19 vaccine and the Johnson & Johnson vaccine. And I think it's because the people that are affected are having an odd autoimmune reaction where it's causing the issues with the platelets. And then I know that later this week, the FDA is supposed to have another meeting to discuss this. But, right in the very beginning, that causality, really should not be assumed. It does need to, it would need to be documented. So it's always something coming up, it seems like. So we may not know until later in the week whether that causality will be shown. All right, then we had our 2020 codes. The codes remain the same for October 2020, but some of the guidelines were updated. At first, we were told that it would be okay to confirm the code presumptive cases. And that was because at first, when you did the lab test, you'd have to send it to the CDC, wait for the CDC to process it, and then send you the results. And during that time frame, the person would be presumed to have COVID. In October 2020, there were enough lab tests out and available where not everybody had to send them in to the CDC or the Centers for Disease Control and Prevention. And so the presumptive was removed. And then they added that screening guideline. So during the COVID-19 pandemic, a screening code is generally not appropriate. And so for the encounters for COVID-19 testing, and that can include your pre-op testing, code it as exposure to COVID-19. And that's the guideline chapter and verse. All right, and then in January of 2021, we had our personal history of COVID-19 added, and that is for somebody that had COVID-19 and it is now resolved. And so then they added the pneumonia due to coronavirus. And this is where they added a new one, the encounter for screening, but then telling us not to use it. But they did update the contact with and suspected exposure to COVID-19. So that has its own specific code. So instead of reporting the Z20.828, you'd now report the Z20.822. All right, so the screening, so what's screening versus exposure? So the screening is you're just checking to see, do they, are they probably maybe asymptomatic and not know it? So we want to check them. But what the guidance says now is that during the COVID-19 pandemic, please don't use the screening code. So once we get out of the pandemic, I'm expecting that there will be updates to this. So now the question is for us, okay, well, is that going to be in October or is that going to be in 2022? And I know we're all kind of going stir crazy. All right, so for exposure to COVID-19, so if you have asymptomatic individuals, whether it's actual or suspected, then you code the Z20.822, the contact with an expected suspected exposure. And then for the symptomatic individuals, and the infection has been ruled out or the test results are inconclusive, you can assign the Z20.822. And so they're just asking you to use the general guidelines for contact and exposure for any additional guidance. And if COVID-19 is confirmed, then it says, see the guideline at 1C.1G, and then that guideline is code only confirmed cases. So if, if it's inconclusive, do the Z20.822. If it's confirmed, then you can use the U07.1. All right, and looking into the crystal ball, coming up, that what has been proposed is U09.9. This is not finalized yet. I expect the list to be published in early June, but they have U09.9 post-COVID-19 unspecified. And this code does establish the causality between the condition and COVID-19. So you would report it as secondary to whatever the other patient's condition is. And they are going to add some codes into the tabular addenda, but they also, during the ICD-10 Coordination and Maintenance Committee, they said that the tabular examples are not going to be exhaustive. But this U09.9 is going to be taking the place of the B94.8, the sequela. Now, they are going to add an excludes to note to the B94 section, because it is possible that they are having, some residual effects of another condition that might be, virus related, but is not the relationship to COVID-19 may not have been established. So expect additional information to come out. During the Coordination and Maintenance Committee meeting, they were saying, hey, can't we have this now? But they are going to wait until October 1st for the normal annual updates for the ICD-10 codes. All right, so let's head into the CPT and HCPCS updates that are COVID related. Now, last time when I was presenting these codes, I was messing with the annotation feature, and I think I accidentally skipped a slide. So I wanted to go ahead and show the Pfizer biotech vaccine codes. So we've got the 91300, which is going to be the vaccine when it is when it's no longer free. And so the administration, the 0001A and the 002A are for the first dose and the second dose. Now for the Moderna vaccine, and this is the slide that I skipped, they have the 91301, which is really not necessarily needed to be used. And then they have the 0011A and the 0012A for the first and second dose. Just the last digit of the 91301 for the vaccine, that correlates to the third digit in the immunization administration, the 0011A and 12A. So as they add more codes for the different vaccines, like the next one, if it's 91302, then we'd have the 0021A, 0022A, and then, 3, 4. Well, and I said that wrong because we have our Johnson & Johnson vaccine, which is the 91303, 0031A. So when they get to the 4, it'll be the 0041A as those come out. So February 27th, they came out with they activated the codes for the Johnson & Johnson vaccine. Unfortunately, it's been suspended distribution, but we may see that picking up here again. Who knows? All right. So they are still working on the AstraZeneca vaccine. The last I saw about the emergency use approval is that it's soon. They were hoping to have a hearing on it in April. So they better hurry up if they're going to have that done. Otherwise, it will be going into May. And then kind of in the hopper, as it were, we do have a vaccine that's in phase 3 clinical trial, which is the Novavax. And they are expecting to get the EUA approval next month. Again, they are 2 doses, 1 month apart. The effectiveness in the UK is 95.6% against the viral, and then 85.6% against the UK variant. And the United States has already purchased 1 million doses. So when we get the green light, we've got it. And no specific codes have been released yet for the Novavax. All right. Now on the future codes, what I wanted to do was, there was a Medler Matters article, the 12212, and it was regarding the SNF consolidated billing codes. I did put a link to the article in my references, but they did publish some vaccine codes and the vaccine administration codes, and they've been reserved for future use. I just wanted to kind of put a caution out there. The codes have been published, but they're not active. And there hasn't been any discussion as to, oh, well, use this one for Novavax. And so I'm sure there'll be some code changes as things arise, because they always seem to. But I did want to let you know that there are codes out there floating around. So if somebody mentions them, just be cautious that they may not be active yet. All right. And I wanted to also do some caution codes here as well for the COVID convalescent plasma. The International Council for Commonality in Blood Banking Automation, or the ICCBBA, has established some codes for CCP. They are inventory control codes. They are not HCPCS codes. So they look like HCPCS codes. They do not act like HCPCS codes. So I just wanted to caution you about those, because I have gotten a few questions about, well, hey, I can't find this code for the convalescent plasma. Why can't I find it? And I just wanted to kind of reiterate that the convalescent plasma is authorized for inpatient use only at this time, and inpatients don't use HCPCS codes. They just use the PCS codes. So if you are using convalescent plasma, then they are reported with the ICD-10 PCS codes. And then the ICD-10 PCS codes are the ones that trigger the new COVID treatment add-on payment codes that you can receive that extra reimbursement from CMS. So they're not looking for a HCPCS code, they're actually looking for the PCS code. So just to be cautious there. And then recently, there have been some codes added to the telehealth services list. And this is an example of time travel, because the spreadsheet out on the CMS site with the list of telehealth services say that these were added 3/30/2021. Well, you can report them starting then, but they didn't get those updated to the site until like April 9th or so. And so a lot of it is for therapy services. So here you've got like your oral function therapies and your tympanotomy, some speech audiometry, a comprehensive hearing test, some acoustics, your evoked auditory test, and then also some your evaluation of your swallowing function, a tinnitus assessment, and such. So I do have a list of those new codes, newly added codes there for you. And then your assessment of aphasia as well. All right, so there's always bumps, and there have been some reimbursement issues. And I want to thank anybody that was at our last webinar, because some of your comments really helped understand some of the issues. And so I've incorporated that within the presentation here. So the Centers for Medicare and Medicaid Services has placed the COVID vaccine, the COVID-19 monoclonal antibodies and vaccine administrations under the Medicare vaccine benefit, basically because the claims would process with no patient coinsurance or copayment amount. And they were initially assigned to existing ambulatory payment classifications. The first dose was to $14.92, which the APC payment was $15.50, the national payment rate. And then the second dose was set to the APC $14.93, which has the $25.50 national payment rate. And of course, those APC amounts do not match the amounts that were on the COVID-19 vaccines and monoclonal antibodies website. So it was, if the payer did not go in and adjust the payment, it's very possible that you were not receiving the correct payment for those vaccines. All right. So on the vaccine administration website, the first dose was supposed to be $16.94 for the national payment rate. And then the second dose, or the single dose, was at $28.39. Now, effective March 15th, they upped that to the $40 reimbursement per dose. And it's no longer dependent on whether it's the first or the second dose. So it's $40 each. Now, there were new APC assignments effective April 1st. Unfortunately, CMS did not make this retroactive, but that's okay. We can live with it. They have the APC 9397 for the first dose of 2, and then the 9398 for the dose 2 of 2 or the single dose product, and the national payment rate is set at $40. Now, the fun part is that those rates are not in the addendum A or B files. They're in a CMS file on the CMS Vaccine Administration website. So if the payer did not go out and grab those, it's possible that you didn't receive the right reimbursement. Okay, and so for the COVID-19 monoclonal antibodies were placed under the Medicare vaccine benefit. So you would submit the claim for the infusion like you would for an influenza vaccine. So yes, that does include the monoclonal antibody infusions. And no, it does not make sense. And I agree. And basically CMS was wanting to do it so that there would be no copayment for the patient, to make it easy so they wouldn't get balance billed, but that doesn't always make it easy for the providers. And so that means that for Medicare, they would like for you to submit those with the 771 revenue code, preventive care services, even though the monoclonal antibody infusion is not a preventive service. The billing instructions say you need to report it that way. And then the diagnosis code Z23, encounter for immunization, needs to be used. Now, the fun part is that the diagnosis sequencing varies by your MAC, because some want the Z23 to be the first listed diagnosis, and other MACs say it's okay just to have it somewhere within your list of diagnosis codes. So the MACs do seem to have instructions out on their websites for how they would like for you to sequence those. So please double check if you're having issues. And then also for any Medicare Advantage patient, claims for the monoclonal antibody infusions and for the vaccine administration go to original Medicare through the end of the year. And then probably what will happen is it will be added to their statement of work for 2022. So we need to keep an eye on that to see what things are going to be in store for 2022. All right, so there are some condition codes. So the A6 vaccines, Medicare 100% payment, or the M1, which is a payer code, is used if you're doing roster billing. The DR condition code can also be added. And then a new one is the condition code 91, service provided as part of an emergency use authorization. And then if you have, of course, any other applicable condition code that might need to go on the claim. And then here's the list of the bill types that it affects. So that also includes like your critical access and other areas there. And just to remind you that this is going to apply not just to the vaccines, but also to those monoclonal antibody infusions. So it's almost like an episode of Twilight Zone. All right, now an update I would like to give you is that one of the questions that we had during the webinar was, a patient came in and they were getting a Bamlinimab treatment and they start to have a reaction, and so they give them Benadryl. So do the monoclonal antibody infusions have to take into effect the injection infusion hierarchy? And the response that I got back was that the BAM treatment is a HCPCS level 2 code and not a CPT code. So basically the injection infusion hierarchy only applies to the injection to the CPT codes and not HCPCS codes. So in this instance, you would be able to use the modifier 52 and report that, because I asked if the infusion is discontinued, do you use modifier 52? And if they said if the infusion was discontinued due to circumstances that affected the well-being of a patient, then it is appropriate to use modifier 52. And so this would also include if you were doing the combo codes, because it's kind of that concept. If you are canceling that, you can go ahead and use the modifier 52. Okay, and then I also wanted to, this was not a question that I asked, but somebody had sent in, hey, somebody had, the documentation says the post-COVID-19 syndrome, can we code that as sequela of the COVID-19? And I thought this response was very pertinent. And they're saying that the post-COVID-19 syndrome indicates that it's just a temporary condition, but that it is not necessarily a sequela of the COVID-19. And so just, so then you would use personal history codes to explain the patient's past medical condition that no longer exists and is not receiving any treatment. And so the sequela is for anything for the residual effect after the acute phase of the illness is finished. So if they've had COVID-19, any condition that might be a residual effect, this is kind of underscoring that you have to show the causality between the COVID-19 and that residual effect that the patient is having. Let's see, and I do have a link to the Coding Clinic Advisor in the references. They do walk through some coding scenarios that you might find helpful. And so I did bring a couple of those examples, such as the post-COVID-19 So terminology is going to start to get kind of to be a sticky wicket. Another example they had there is the emergency department patient comes in and they're complaining of, their throat tingling and a tightness of chest after their COVID-19 vaccine. And that causal relationship is documented. And so this is the diagnosis sequencing that was suggested. You can use the T78.49XA other allergy, and then R09.89 other specified symptoms. They did caution that you should not use the T80.62XA, which is due to a serum reaction of the vaccination. And that is because these vaccines are not serum based. And they did say that, if that anaphylaxis is documented, then you can code for the anaphylactic reaction. So, just because they're saying, hey, my throat is tingling and I've got tightness of chest, does not necessarily mean that it's an anaphylactic reaction. But if they do state that, hey, patient is having an anaphylactic reaction, then, by all means, go ahead and assign that. All right. And so they do have several other examples in that coding clinic advisor that walks through different coding scenarios. And it's very helpful as well. So you might, if you're having some issues, how you're trying to figure things out, that might be a very good document to read. All right, regulatory updates. Oh, you never know. The public health emergency has been renewed for another 90 days. So that takes us to July 20 something. And so then it will, unless it's evaluated sooner and the pandemic is declared ended. However, since it's possible that we'll not have everybody vaccinated by then, it's very possible that it will be renewed again. So we'll just have to wait and see how it goes. Dr. Fauci is now stating that there's a high possibility that we'll have to have booster vaccines for the COVID-19. And at this time, I don't know if they will, I don't know what the coding guidance will be for those. And, for those shots like the Pfizer, Moderna, Novavax, if that will be we'll just need to get one shot, or if it will be another 2-dose schedule. It's just really too soon to know right now. And so that's kind of a stay tuned. It'll probably be part of the, oh no, not another COVID-19 coding and billing webinar. And now the emergency use authorization for Bamlinimab only treatments has been revoked. Because of the different variants that are starting to come out, they're stating that just the Bamlinimab by itself is not, the risks no longer outweigh the benefits, and it's really not helpful for treatment. However, the combination drugs are still available for use, like the Bamlinimab and the Etsy, the Etsy drug, which I don't know that I want to try to pronounce because I will totally butcher it. And I'm very sad because at least I could pronounce the Bamlinimab. And then the other combination drug where I would butcher the pronunciation of both of them. Those are still good to go, and you're fine to be able to use those because they're saying that you really do need to be efficacious. You need to have both drugs to be able to treat the patient, especially as we're now starting to find those pesky variants coming in. Now, during the ICD-10 Coordination and Maintenance Committee meeting, they are suggesting that they go to the twice yearly update, because I'm sure you noticed that the only really new code suggested for October of 2021 is the U09.9 for that the post-COVID diagnosis. There weren't any others that were really COVID-19 related that were suggested. So they're suggesting that they would have kind of that twice yearly, so we can kind of get in the cadence of having the have updates more often. However, they're not able to kind of get that in place by the October 21st deadline. So they were expecting to have that start April of next year. And that April release would be expected to have fewer codes than the annual release. The annual release process where and so I'm expecting then they would need to have additional coordination and maintenance committee meetings. They have those usually through Zoom or YouTube. I've not attended them, but I usually read the notes, the transcripts and stuff, and it's nice to be able to listen to it on my own time. And then sadly, the CMS COVID office hours was discontinued on April 6th, was their last official office hours call. It was a little sad, but they did state that COVID-19 issues may be covered in the open door forums by provider types. So if you have, they've got different ones for rural health clinics and for physicians and qualified healthcare providers, and hospital outpatients. So you can attend the open door forums and ask your COVID-19 questions through there. So those were very, very helpful. And so I'm really kind of sad to see them go. And so they did start some new condition codes. They were effective back February 1st. They have 90, which is the service provided as part of an expanded access approval. And that used to be known as the compassionate use approval. And then we have 91, which is a service provided as part of an emergency use authorization. So that's going to be your COVID-19 vaccines, your monoclonal antibodies, your laboratory tests and supplies, just really too much to list. But it's also for some, some masks that might be things that you wouldn't necessarily report. And I do have a link in the references that takes you to a list of the stuff that was authorized under an emergency use authorization. And with that, I believe that we are to the questions portions, but just I wanted to kind of cover this. I've got the list of the ICD-10 guidelines if you want to take a look at and go through a kind of a retrospective look. The ICD-9 Coordination and Maintenance Committee meeting link is there. So if you wanted to take a look at the transcripts for that new code, the U09.9, that's always fun. And the third bullet point is that link to the emergency use approval authorization list. And then some information on the vaccines. And then that last link is on the page is to that MedLearn Matters article that I referenced regarding some of those codes that were listed in the SNF consolidated billing that have not really been authorized yet. Here's the link to the coding clinic advisors. CMS has updated their COVID-19 vaccines and monoclonal antibodies page to include the updated information on the Bamlinimab. And then if you wanted to go out and read the public health emergency little blurb, it's very, very short, just saying they're renewing it. And with that, I will turn it back over to you, Marie.
Awesome. Thanks so much, Ardith. You're always so great and so informative. So just a reminder for everybody, please continue to type your questions into the Q&A panel so we can make sure that they get answered. And we already have a couple questions, Ardith, so I will read the first one to you. Okay, if Z8616 intention is to use if COVID is resolved, how would a person still experiencing symptoms, long haulers, SOV, weakness, etc., be assigned?
All right, so if they are still, if there is a cause, if that cause has been established, then they could be coded as the sequela, the B94.9, and you would also report the residual effects that they're having. Because I think on, like one of the examples they gave for that, the U09.9, they also had like the loss of taste and smell. So if they're still experiencing that, you could still report that.
Awesome. Okay, next question. Any guidance for the use of the CS modifier?
Okay, well, the CS modifier is supposed to be used to bypass. So if a patient thinks they have COVID and they present and they are saying, you know, I've got they list their symptoms, I think I've got COVID, and you end up ordering a COVID lab test for them, you would apply the CS modifier to that evaluation and management visit. And that could also be observation, and then it will waive any coinsurance or copayment for that evaluation and management visit. Now for Medicare, they're saying for the lab tests, you do not need to use the CS modifier because there is already no copay for the patient. So it's just redundant. And so it would be anything where there might be a patient copay, because that's signaling to the insurance company, you need to process this without a patient copayment.
Great, thank you. Okay, next one. We are getting paid for the MAB with Revcode 260. Do you think we need to go back and rebill Medicare on these?
Well, I'm kind of surprised you're getting paid on the 260. Just verify, I would verify with the MAC, because the reports that we were getting from several attendees at our last webinar was that they had used 260 and they were denied. And it's possible that your MAC went in and adjusted what revenue codes they would accept. Whichever one they'll take, I would, if it ain't broke, don't fix it. But just verify.
Awesome. And okay, another one. Do you have any billing recommendations for COVID vaccines admin during IP stay and/or vaccines MAB treatment that falls within 3 days of IP stay?
Yes, there is information that it's you would bill it just like you would if you were giving the flu shot to the patient that was in the facility. They would like to have that billed on the 12X bill type with the revenue code and 771 and the diagnosis C23. So that's kind of the Part B hospital service paid to a hospital inpatient, I think, is the bill type. Sometimes those get scrambled in my head.
Awesome. These are great questions, everyone. Keep them coming. Next one, is there an MUE for the U0005 use?
That is a good question. I have not looked at that, but I do have access to the information. So if I stall long enough, I can actually sign into the VitalWare Knowledge product and go look that up. Because we did have a question come in if you could report the U0005, which is the high throughput add-on payment, if that could be reported with the 876 code And unfortunately, it says within the descriptor that it can only be used with the U003 or the 0003 or 0004. And it looks like there are no MUEs for that U000 5. It's trying to, okay, how many zeros came out of my mouth that time? So it's U, 3 zeros and a 5.
Okay.
And no, there is no MUE at this time.
All right. Next question. Do you know if all insurance companies are accepting the M code, such as M0239 for the administration of the drug, or should we use 96365 for some insurance companies that don't accept the M code?
Well, that's the tough part. It would be nice if they would accept the M codes for the administration. But of course, payers can make their own policies. And if they're not accepting the M0239 code, they should be accepting the 964 codes for the monoclonal antibody, the high-risk medication and monoclonal antibodies. So, and I always get the push code and the and the hour administration, but since there's, the 2-hour administration on this, you would use that, the 96413 for the, and for the an hour at, the initial hour and then your subsequent hour as well.
Great. Okay, still having a few more questions come in.
Yeah, unfortunately, if they would all just do what I wanted to, it would be so much easier for all of us. But unfortunately, they kind of make their own rules.
Okay. Would you still use the CS modifier if a COVID test wasn't ordered because of patient refusal, or the provider didn't think it was necessary, but the encounter or treatment plan is still very much COVID related?
That is a very detailed question, and I would like to go back and reread, because I'm thinking that when it initially came out, it said that that the evaluation and management resulted in the order for the test. So if there's an order for the test, then it would be usable. But if the client, because see, then I'm thinking, well, then why did you even go if you didn't want to get tested? But there could be other conditions. So I should not be judgmental. And so I would like to double check the regulations on that one just to be sure, because I don't know that it's been addressed about, well, what if the patient, the test is ordered, but the patient refuses. And so I'd like to make sure I've got that accurate for you.
Okay, we'll get back to that person then. Send an answer. Okay, next question. My question deals with the CS modifier when patient is in the ED and admitted to inpatient. Would this modifier be used on an E&M emergency department code if the patient enters the ED and the test is performed to place the patient on the correct IP unit, COVID unit versus medical unit?
Okay. Oh gosh, okay, so that is nuanced. So if the patient comes in complaining that they've got COVID and they have the COVID test, then the CS modifier would be used. But if they were not complaining of COVID symptoms, it would seem that it was just a screening. But I think it's that it states that it's the evaluation and management service that results in the order for a COVID test. I don't think there's any stipulations on whether it's screening for placement on the correct floor. So the modifier should be appropriate in that instance.
Okay. And it looks like as of right now, we only have one more question.
Okay.
So we might end a couple minutes early, but we'll get this one done. We are not charging the admin charge in an inpatient setting. Is there additional reimbursement if submitted like the flu vaccine? Where can I find the information regarding reimbursement in an inpatient setting?
Okay. That would be on the vaccines and monoclonal antibodies website. I've got the link here. So let me see if this works if I try to click my link there. And of course it goes on to the other screen. So let me pull that over here. All right, so they have all kinds of information here for you, and this is the pricing. And they do have the monoclonal antibody infusion program instruction, has a ton of information. And then it does have the information on coding over here. And it does state that you can, do this on the 121 bill type. And so, but I will get you the reference and send that out so that you don't have to go clicking all over the place. I can kind of give you the Cliff Notes version. Because I know that it's on, it's either here or it's Medicare billing for the vaccine shot. And so it just kind of walks you through. And it also, so how to, it just kind of walks you through here. So it's basically the same way you would for an influenza vaccine, is you would submit it for your inpatient hospitals. And the codes are not part of the SNF consolidated billing. So you have the ability to report those codes.
Awesome. We actually have a couple more that just came in. Ardith, if you want to open the chat box, there is one that just came in and I'm not too sure what the question is. I can read it to you though, if that's easier for you. Oh, it looks like it might be a comment.
Okay. Yeah, someone's saying that vaccine administrations have been denied and appealed as per payer guideline, requesting to append with the CS modifier with the admin code. And that's for TRICARE, Humana, and Superior in Texas. So thank you for that. That's very helpful. So unfortunately, the payer may dictate what codes need to go on the claim. And so if they want the CS modifier, they're going to ask you to have that on the claim, which to me, it doesn't make sense because they can set up their claims processing to not have a co-payment for those codes.
Okay. I think one more question came in. This might be the last one. When a patient is in ED and then went to the floor for observation and had a COVID test in ED, we are adding the CS modifier to the ED and E&Ms and the first day of the observation charge. Is this correct? Do we add the CS to just the first day or all the observation days, hours?
I would add it to all the observation days because the the observation is listed as a service that can have the copay waived in the, I can't remember if it's the CARES Act or the Family First Act, but I will double check. But yes, for the list of E&M visits that are covered, it does include observation. And so in that instance, I would be cautious and append it to each day.
Okay, we have a couple more coming in actually. We'll keep going until we don't have time anymore. Hi, when receiving MAB infusion in the ETD, should Z23 be first listed?
That is going to be a payer policy because some MACs are saying they want the Z23 listed first, and others do not. And then, all your Blues and Aetnas and Humanas and stuff can also dictate whether they want it first listed or not. So I'm sorry about that. I wish it would all be static and we could all be on one page, but unfortunately, I'm not in control. So, but yeah, unfortunately, it might be payer policy that dictates that.
Okay. If a patient had COVID-19 in January 2021, but the documentation does not specifically say it is a history, can the history code still be used with the patient is having cough during and since having COVID-19?
Oh, that is a very good question. And if they're able to establish the causality, then it's still kind of active treatment for the patient. And so the personal history is not used. So it's going to depend on how the documentation goes for that. And so they do have in that, the coding clinic advisory, they do have some documentation on that. So I can get you the guidance, the regulatory guidance on that. But they're saying if it's still, if the cough is caused by as sequela of the COVID-19, then it's still under active treatment. So it's not yet personal history.
Awesome. And we have one more, but we will reach out to you individually. I just don't want to get kicked off of here for any reason. We are at our hour time. So thank you so much, Ardith, for presenting for us today. And thank you everyone for attending. We hope you enjoyed the session and found it very informative. If you have any questions, you can reach out to us after and we'll make sure to get those answered for you. We will be posting the presentation, which also includes the reference guide and the recording of today's presentation, along with the CEU certificates will be sent out later today following the presentation. And I think that's it, Ardith.
All right. Yep. I'll start working on the questions that came in as soon as I can so we can get those, the answers to you and post it out on the website.
Awesome. Thank you so much, everyone. Have a great day.
All right. Thank you.
Okay, thanks. Bye.
Bye.